Hello, today with this FERNE presentation we will be discussing the care of emergency department patients with dizziness and vertigo in an attempt to appropriately diagnose and treat patients with a potential serious central etiology. My name is Edward Sloan. I'm an emergency physician in Chicago. I work with FERNE, the Foundation for Education and Research in Neurological Emergencies, ferne.org. I have no financial conflicts. I'm the FERNE president and board chair. So now that we know what are the consensus definitions of important clinical terms, now let's consider the clinical history in patients who might present with dizziness or vertigo. The first thing we should consider is syncope or near syncope. Why? If a patient felt faint or they actually had a syncopal episode, that really is the first diagnosis that can and should be made. In other words, did they almost pass out like when you see blood, or did they actually pass out? If there's no syncope or near syncope, if you can determine unsteadiness or directional pulsion, walking down the hallway bumping into one wall because you can't walk straight, that really is a sign that there could be some cerebellar or cerebral ischemia and causing this unsteady gait or cerebellar ataxia. Then go on to asking questions about vertigo. Did the patient feel as though they were moving even though they were still? Did they feel a spinning, rocking, or tilting motion? Or did they feel as though they were falling downward as in an elevator? Did it occur with movement of the head? Did it occur at rest without any motion? Have they had this episode before? And are they having these vertigo symptoms now? This relates to the concept of acute vestibular syndrome, and we'll be talking about that. Last, you can ask, was there some sensation of disturbed or impaired spatial orientation? In other words, when looking about, did they feel as though there was something not right in the world around them? Or did they feel giddy, lightheaded, or some symptom that they would describe as dizziness? Lastly, you could go to the past history and ask whether or not the patient has ever been diagnosed with syncope, near syncope, vertigo, or dizziness in the past. And then you can ask questions that would relate to systemic causes of dizziness. You can ask whether the patient's ever been treated for a low blood count, low blood pressure, low heart rate, low blood sugar, or any cardiac dysrhythmias. So our take-home points from the clinical history portion of this examination of the dizzy and vertiginous patient, we consider the order in which we ask the questions. And I would suggest you go in reverse order and talk about dizziness last. First, talk about syncope or near syncope. Then talk about unsteadiness with standing or gait. Then probe vertigo symptoms, the type of vertigo, the timing, and the triggers. And then discuss feeling dizzy last. And once you get to that point, you can then review systemic causes of dizziness or weakness, such as a low hemoglobin, low glucose, low blood pressure, etc. So our diagnoses, what should we consider when we talk about our clinical history? I believe the systemic diagnoses can be determined relatively efficiently, either with the history or a brief directed laboratory evaluation, including an EKG. Syncope or near syncope can be determined based on the history. Unsteadiness with standing or gait, which suggests possible cerebellar ischemia, can be determined both on the history and a brief exam. And then vertigo symptoms, whether it's current or continuous, this would suggest acute vestibular syndrome. If it's spontaneous and episodic, that would be spontaneous episodic vertigo syndrome. And last is the episodic vertigo triggered, and we'll talk more about these three diagnoses in a moment. Lastly, nonspecific dizziness is a diagnosis of exclusion after you've considered all of these other diagnoses. So what are the relevant disease states that can cause dizziness and or vertigo in patients? This is a list in alphabetical order of diagnoses that could be related to dizziness or vertigo. The first, alternobaric vertigo, involves changing pressure involving, for example, a ruptured TM. When scuba diving, this will cause the patient to have a dizziness symptom. But there are other diagnoses listed here. Some are benign and or peripheral, some are central. On the second page, we go all the way through Wallenberg syndrome, which is a neurological condition that is also referred to as lateral medullary syndrome or posterior inferior cerebellar artery syndrome, which is a significant central etiology for dizziness and vertigo. So let's go back and consider the three vertigo types that may be encountered in patients with dizziness and vertigo. In this table, you consider what are the potential types of vertigo and what are the potential diagnoses related to that. I refer to the emergency medicine practice monograph developed by EB Medicine, written by Jonathan Edlow, and this is a peer-reviewed document. It's called The Timing and Triggers Approach to the Patient with Acute Dizziness. This is a good monograph, and in Table 1, you see there are 3 rows that correspond to the 3 types of vertigo we might encounter. And so for each of these 3, there are benign diagnoses in yellow on these slides, and then there are more serious diagnoses in red that correspond to these 3 types of vertigo. And we'll talk about these specifically in a moment. So the diagnoses related to dizziness and vertigo require us just to consider for a moment how the peripheral vestibular system works and what are potential areas centrally that could be involved if there is ischemia or infarct. So dizziness and vertigo pathologies fall into 3 major categories. The first are systemic causes. Is there hypovolemia, electrolyte abnormality, low hemoglobin, low glucose, low blood pressure? These are systemic causes. Is it peripheral? And by peripheral, we mean specifically abnormal vestibular function in either ear. And then lastly, we consider whether centrally there is central ischemia, an event such as an infarction, and or some lesion that is causing the vertigo to occur. So what is the normal vestibular anatomy and mechanisms, and what are the at-risk posterior circulation areas to which we refer? I again go back to our EB Medicine monograph by Jonathan Edlow, published in 2019. On page 4 of the monograph in Figure 2, the vestibular organs are identified. The utricle and saccule sense vertical and horizontal acceleration, change in speed. The 3 semicircular canals sense movements in the 3 different directions. And then lastly, the vestibular nerve carries the input to the brain from the periphery so that our brain knows how to guide our eyes so that our eyes stay in reasonable alignment even if our head is moving in a direction or accelerating in a direction. Now, what about posterior circulation ischemia or stroke? So the posterior circle of Willis blood flow, if disrupted, can cause problems in many areas of the brain. This is an excellent picture that identifies areas that are at risk. So if there is posterior cerebral blood flow disruption in the vertebral basilar system, you can have diminished blood flow and changes in cortical function, including the medial temporal and parietal lobes, here in blue. In purple, there can be disruption in blood supply to the thalamus. In green, the occipital lobes can receive diminished blood flow if there's posterior circulation problems. In orange, the brainstem, including the midbrain, pons, and medulla, may have diminished blood flow if there's vertebral basilar ischemia. And lastly, the cerebellum, in pink, can also receive diminished blood flow with vertebral basilar insufficiency. When considering the care of emergency department patients who present with dizziness and vertigo, it's important to consider some case studies to frame our further discussion of how we are to examine these patients and provide appropriate disposition. So the first is a dizziness case, a lightheaded 70-year-old. This 70-year-old female presents with lightheadedness for 5 days, and she states it's worse when she gets out of bed quickly in the morning. She says the dizziness sometimes will wake her up out of her sleep. She has hypertension. She's on cholesterol meds. Her vitals are found to be okay. She has a normal neurological exam. She has no nystagmus and is not found to be orthostatic. The question is, should a CT be ordered, and if so, why? Our second case is a syncopal 58-year-old male. Diabetic, he had some nausea and vomiting, ×3. Syncope reported, but he said he had such bad vertigo he had to lower himself to the ground. It began 3 hours previously and suddenly. He has some fast component nystagmus to the right, especially with gaze to the right. His HIT test is positive. His skew is negative. He's mildly unsteady, but he has relatively okay gait. The question is, based on this, do you call the stroke team? Our third case is a 44-year-old male with dizziness, and it's brought to you at the time of sign out, and one provider says to you, hey, can you just check the CT? This is a 44-year-old male, history of hypertension and diabetes. He has 6 hours of continuous dizziness. He appears to be unsteady. He says, I just feel like I'm drunk. He has normal vital signs, but he has left beating fast nystagmus with gaze. He seems to be improved following treatment with benzodiazepines in the emergency department. And of course, the famous sign out, if the CT is okay, can you just send the patient home with some meclizine? And with that, I say thank you. For any further information, I encourage you to go to FERNE.org, or we can go to the FERNE.org channel and subscribe on YouTube, or you can send us an email at fern.org@gmail.com. Thank you for your time and attention to this important clinical information related to the neurological emergency of acute vestibular syndrome in emergency department patients. I'm Edward Sloan. Again, thank you and have a good day.